Hi everyone, my name is Qualita Joaquin. I completed this rotation at Senior Medical Associates, a geriatric primary care clinic in San Diego, California. Today I will present a 65-year-old Latina female who came in with complaints of a racing heart and difficulty sleeping and was diagnosed with Graves' disease. This case was meaningful to me because her symptoms could have easily been mistaken for anxiety. She initially believed stress was the cause. This experience reminded me how important it is to avoid labeling symptoms too quickly and to rely on objective findings. For brief case presentation under subjective, this patient reported a 2-month history of intermittent palpitations occurring at rest and lasting 10 to 20 minutes. She also described trouble sleeping, irritability, heat intolerance, fine hand tremors, and an 8-pound unintentional weight loss despite no change in appetite. Her past medical history includes hypertension and hyperlipidemia. Family history is significant for hypertension in her mother with no known thyroid disease. She is retired, lives with her husband, and her daughter helps with healthcare decisions. She drinks about 2 cups of coffee daily and denies tobacco or alcohol use. Review of systems showed weight loss, palpitations, heat intolerance, tremor, and difficulty sleeping. She denied chest pain, fainting, shortness of breath, swelling in her legs, severe headaches, heavy sweating episodes, panic attacks, depression, or hallucinations. The rest of the review of systems was negative. For objective information, her height was 64 inches, weight was 140 pounds, and BMI was 24. Her vital signs showed a heart rate of 104 beats per minute and blood pressure of 148 over 78. Oxygen level and temperature and other vital signs were normal. On physical exam, she appeared well and was not in distress. Heart exam showed a fast but regular rhythm with no murmurs. Neurological exam showed a fine tremor in both hands. Psychiatric exam showed a mildly irritable but appropriate mood with no signs of anxiety or depression. The rest of the physical exam was unremarkable. Lab results showed a very low TSH of less than zero point zero 0.01, elevated free T4 at 3.2, elevated total T3 at 265, and positive thyroid stimulating immunoglobulin antibodies. For assessment and critical thinking, at this point, I collaborated with my preceptor about the case. When developing our differential diagnosis, we considered generalized anxiety disorder, pheochromocytoma, and thyroiditis. Anxiety was possible because of her sleep problems and irritability. However, the abnormal thyroid hormone levels showed that her symptoms were caused by an endocrine condition. Pheochromocytoma was considered because it can cause a fast heart rate and high blood pressure, but she did not have the typical severe headaches or repeated sweating episodes. Thyroiditis can cause temporary hyperthyroidism, but the positive thyroid antibodies support Graves' disease instead. The key findings that led me to the diagnosis were her unintentional weight loss, tremor, persistent tachycardia, suppressed TSH, and positive thyroid antibodies. We reviewed the 2022 American Thyroid Association guidelines and current literature on thyroid disease in older adults to help narrow our diagnosis and guide treatment. Because she is 65 years old, we were also concerned about her increased risk of atrial fibrillation, which is more common in older adults with untreated hyperthyroidism. For our final diagnosis, our primary diagnosis, we came up with Graves' disease without thyrotoxic crisis. This was supported by suppressed TSH, elevated thyroid hormone levels, positive antibodies, and her clinical symptoms. Her secondary diagnoses include hypertension and hyperlipidemia, which are currently stable. For the plan and evidence based practice, according to the American Thyroid Association guidelines, methimazole is first line treatment for hyperthyroidism in non pregnant adults. I started methimazole 10 milligrams daily. I chose methimazole over propylthiouracil because it has a better safety profile and lower risk of liver injury. Propranolol 20 milligrams every 8 hours was started to control her heart rate and reduce symptoms. Baseline complete blood count and liver function tests were ordered before starting methimazole to monitor for agranulocytosis and liver toxicity. An EKG was obtained because of her fast heart rate and increased risk of atrial fibrillation. Her blood pressure was mildly elevated and may be partly related to the thyroid condition, so I will reassess it once thyroid levels improve. She was referred to endocrinology for continued care and will repeat thyroid labs in 4 weeks. Alternative treatments such as radioactive iodine or surgery were considered but not selected at this time because medication therapy is appropriate for newly diagnosed Graves' disease. For the education and follow up, she was educated on warning signs of infection such as fever or sore throat and instructed to stop the medication and seek care if those symptoms occur. I advised her to limit caffeine to no more than 1 cup per day and to avoid caffeine later in the day to reduce palpitations and sleep problems. She was also advised to avoid iodine supplements. Follow up scheduled in 2 weeks to reassess her heart rate and blood pressure. For the holistic approach and caring science, in caring for this patient, I applied a holistic approach by addressing both her physical symptoms and her emotional concerns. She initially believed stress was the cause. Instead of dismissing her belief, I listened carefully and validated her feelings. I applied Jean Watson's caring process of developing a helping, trusting relationship by actively listening and involving her daughter in the discussion. I also applied Watson's teaching learning process by providing clear education about her diagnosis, medication side effects, and lifestyle modifications, and by tailoring the discussion to her level of understanding. In Latino culture, family involvement is often important in healthcare decisions by respecting her cultural values and including her daughter in the discussion. I helped improve I help improve her understanding and comfort with the treatment plan. I also collaborated with my preceptor and will continue interdisciplinary collaboration with endocrinology to ensure safe long term management. This case reminded me that good care requires both scientific knowledge and compassionate communication. In summary, this case strengthened my ability to think critically, apply evidence based guidelines, and avoid premature diagnostic closure. This case will influence my future practice by reminding me to always confirm psychiatric like symptoms with objective data before making a diagnosis. It reinforced my importance of treating the whole person, not just lab values, and combining science with compassionate, culturally sensitive care. Thank you.